go ahead and move to the next slide. So our usual meeting norms, please stay muted to minimize the background noise, raise your hand, or use the Q&A link to ask questions. Next slide, please. We'll leave it here for a few, maybe about a minute so everyone can sign in. And the sign-in sheet will also be in the chat. Okay. Let's go to the next slide. So I'll go over a few of the reminders. The first one is please submit your invoice for your final payment of 10%. We haven't received very many, and I'm sure that you guys all could use your funds to continue to create your capacity, build capacity for your mental health services, your wellness spaces. So please submit your invoice. Next slide, please.
Why, Richard?
This is just another friendly reminder about the Youth Wellness Summit that we have coming up in a few weeks. On April 7th, it will be at the SBCSS San Bernardino, the Dorothy Ingram building. So please register to participate and attend and join us for a fun day. Next slide, please.
Oh, really?
Marwa, do you go ahead?
Yeah, I can go ahead and talk about this. So this is a stimulation-based training that we are hosting on April 20th from 9 to 3 in Rancho Cucamonga. And really the intention of this training is to help participants understand the challenges that our youth face every day in, multiple different systems. So the intention is for this to be very interactive, hands-on, and then after coming together to identify just ways to support our youth that have to navigate multiple different systems. So if you're interested, Karen's going to go ahead and add the link in the chat and just make sure that you're registered. It's an all-day event. Thank you.
Thank you, Marwa. And we do want to spend some time to acknowledge Silver Valley. They submitted their first claim. And I don't know if Tammy's on or Elizabeth is on, but I know they were planning on framing their check. So let's continue to consult and collaborate with one another so that we can make sure that we are properly serving our kids and, serving them to the best of our ability, and also using our CBOs to assist where we know, we have a gap and we can't always meet every student's needs. Yay. So yay for Silver Valley. Okay. I'm going to go to the next slide. You're too far ahead. There you go. I am going to introduce Pacific Clinics, who is going to talk to us a little bit about working with CBOs and utilizing them as partners, whether they're affiliated or embedded in your LEA. We're not promoting you have to work with them, but we are simply really trying to encourage and highlight and help you identify ways that you can partner with the CBO to leverage the CYBHI work in the fee schedule. So I'm going to go ahead and turn it over to Lacey and Patrick. Thank you guys for joining us.
Yes, thank you. Thank you all for having us. My name is Lacey Castellisi. I'm the executive director at Pacific Clinics that oversees our education programming for the state. I have been with Pacific Clinics 10 years, going on 11. I have 16 years in the field of working in education and behavioral health. I started early in my career working with students diagnosed with autism, doing behavior interventions, working in special education, and then branched out into student services, wellness centers, community school efforts, and now the launch of the CYBHI multi-payer fee schedule. So really excited to be here to kind of tell you a little bit about Pacific Clinics, what we've been doing in the ed space, and then answer any questions you have about the fee schedule and Congratulations on your first claim. Really exciting stuff. So I'll hand it over to Patrick to introduce himself.
Hi, good afternoon. My name is Patrick Anderson. I'm one of the senior clinical directors with our education services with Pacific Clinics. And my role is to actually expand access across the state for all manner of services, really focusing on CYBHI and leveraging partnerships with school districts. I started this work when I was fresh out of high school. I went back to work in schools as soon as I left. And I've really enjoyed getting just that relationship going with different schools in different ways. I started in special education as well, but I found myself really thriving on relationships with others and went back to school for mental health. And I've been doing that for pushing 14 years now. So very excited to partner with school districts to bring more services to students to increase those accesses.
We're ready for the next slide. All right, so a little bit about Pacific Clinics. As you can see, we're a statewide agency. We serve over 40,000 children and families each year. Our workforce expands. I think now we're pushing 2,500 employees. And you can see the various regions that regions or counties that we have services in, which include our integrated care, developmental services, our outpatient and psychiatry, substance, foster, ECM, crisis, and then today we'll talk about our education and our school-based services. Next slide, please. All right, so continuum of support. So at Pacific Clinics, we like to talk about the framework in 5 components of how we support students and we support LEAs and schools with services. And so the first one is prevention, right? So promoting overall student well-being. We really want to look at how we can prevent problem behaviors, mental health issues from happening in the first place, and really targeting 0 to 5 family dynamics. And what is really cool is that now we can leverage the fee schedule to fund these services on school campuses and outside of the school setting. The second type of support is school-wide student supports. This is available to all students. So this is where we're looking at Tier 1, Tier 2, and Tier 3, and what that looks like on a school campus. And this, again, is covered by the CYBHI multi-payer fee schedule. And then when we get into number 3, 4, and 5, this, how I like to see it is they're all Tier 3, but at different levels of acuity, right? So 3, we're looking at targeted behavioral health services for students that are at risk or showing early signs. Then we move into 4, which is our specialty mental health programming, which targets students with Medi-Cal. And that's really more focused mental health treatment and crisis intervention. And then moving into special education, where we partner with special education teams for specialized instruction and really ensuring that IEPs really serve the student and their needs for inclusion.
As a provider of services, we spend a lot of time in mental health, especially the specialty and the special ed side of the house. But post-COVID, grant funds and things like that really changed education services and how we can push onto campuses. And now we're really excited to leverage CYBHI to create sustainability with that, because we understand funding sources change rapidly.
Yeah. Next slide. All right, so let's dive into prevention. So 0 to 5, we obviously want to get them in as soon as we can for prevention. Look at school readiness and family well-being. Addiction prevention, I think this has been Patrick and our biggest push over the past couple years, is really working with districts on how we can help promote healthy decision-making, coping skills, awareness about substance use, and really help build protective factors, resilience, and building a network of students that help each other to make healthy choices as they navigate through elementary, middle, and high school together. Social emotional learning, this is the foundation of everything that we do. Understanding emotions, understanding your relationship to others, and really, developing empathy and responsible decision-making that carries, through the trajectory of your life. The last 2 are classroom management and community engagement. So classroom management is where we could really capitalize on tier one interventions and fill that gap for LEAs or teachers that just don't have capacity to roll out a full classroom management procedures on their own, that we come in and help and be that support person in establishing clear expectations, routines, and really fostering a positive and welcoming environment for students. And we can't do that without community engagement, right? So how do we get families involved in this and be a part of the classroom environment, be a part of events, and really be a part of the services that we offer to make it well-rounded.
And this prevention step is where we can really utilize wellness coaches to get into classrooms, provide that SEL, to collaborate and consult with teachers to really manage the environment, to create a space that all are welcome.
Yeah, yeah. All right, next slide. All right, well, we can't talk about MTSS without looking at a triangle, can we? And so we wanted to highlight, I know I'm preaching to the choir here for tier 1, tier 2, and tier 3, but I wanted to highlight some of the trends that we have been seeing across the state that are gaps and what we've been helping various LEAs and schools implement. And I really wanted to highlight at tier 2, the use of check-in, check-out systems. I think it's been kind of a rote learned, student comes, they bring me this piece of paper, I look at it, I mark it off that they did it, and then we're moving on. Or we're really trying to shape the focus to be relationship driven, right? How does the student feel connected to the classroom, feel connected to that teacher, feel connected to the responsibilities and the tasks that are presented to them when they're on a school campus, and really feel like this positive interaction is happening. So we've done a lot of work with check-in, check-outs, and then restorative practices. How can we have this alternative to suspensions, right? Not every action that a student has on a school campus needs to be punishment-based. And so how can we teach alternative behaviors and really use that peer model to keep students on campus in a classroom learning is our goal here. And then lastly, I wanted to highlight our wellness centers. It's been really fun, I think, over the past 3 years, the amount of wellness centers that we've been able to help launch. We'll come on campuses and help LEAs launch the wellness center and then pass it off to their staff so that they can, tap the fee schedule and make sustainable systems. Or sometimes we come in and we are the service providers that, keeps the wellness center going. And so we've been really, really diving into universal screening and using the wellness center as a hub for this, so that we can really make sure that the services that we're providing to students match their need. And certified wellness coaches and our clinicians obviously have been the driving force in making this really successful. And it's been a really, I think, fun initiative this year and last year, our wellness center approach. I don't know if there's anything else you want to add, Patrick.
Yeah, we'll spend some more time diving into the partnering piece, but just know that when you partner with a CBO, that they can move between all the tiers and they can scale, which is, I think, a benefit of having that partnership. So if you see an increased need for, tier 2 at the beginning of the year, you provide that service, the CBO jumps in and does that work. But then throughout the year, you might see additionally, maybe there's more tier 3 later in the year, maybe there's more SEL you need to implement, or just more intervention strategies you need to do. And partner with CBOs allow you to scale those needs very, very quickly. That's a huge benefit.
Yeah. And I was thinking about some of the principals that we've worked with over the past couple of years where they were trying to launch restorative practices and getting alternatives to suspension set up. And they were like, hey, PC, I want you to figure this out. I want you to manage this section for us because it's really somewhere where we're struggling. And so every time a student got referred to the office for a disciplinary referral that would possibly lead to suspension, a lot of it was vaping, substance use, showing up to school drunk. So they would call us and we would deploy a team that would show up on campus. We'd debrief with principal and student, and then we would create that restorative plan and give that to the school team. And as, a working team now with school and PC, we were able to implement the restorative practices and keep those students on campus. So that has been really exciting for me to see over the past year or two. Great. Next slide, moving on. We're zooming through this. All right. So this slide highlights our targeted tier 3 approach when we work with districts or school sites. And when we get initial referral, we're tapping the fee schedule to utilize screeners, right? So we first start off with assessment, and it could be brief, it could be comprehensive. It really depends on the presenting problem and like the acuity of needs. And from there, that screener or that brief assessment dictates our care plans. And our care plans are really brief, targeted plans that have a goal. And in sessions, what we're using these care plans for is for data collection, right? So all of our providers, when they're on a campus, they'll have a care plan for each student. And the expectation is that each time they come in contact with that student, they are collecting data on the intervention that they're implementing. And then it's up to our managers and our clinical team to be analyzing that data and then make decisions of how to move progress forward. We typically like to be really paced when we come to tier 3 because we have to get that momentum, right? We have that student engaged, we have the care plan, we have a goal going, and we want to capitalize on that momentum to keep things going. And so with that said, we provide services across all settings. So the setting could be on a school campus, it could be in a library, a wellness center, it could be in the community at a coffee shop. It could be in homes. Sometimes we have families that, are working all day and then we need to meet them at their job on their lunch break after school, at a coffee shop. So we'll show up and meet the need there. And then the last two pieces I've been seeing is kind of the trend across the state is generalization and teaming. And so when we speak about generalization, we're talking about, can this student generalize the skill across all settings of their life? When they show up into a classroom, when they're in the therapy room, when they're out in the community, when they're doing extracurricular activities, when they're at home with their family, all these skills that we're teaching, can they do it, right? And so we want to see this in real time to ensure that what we're teaching is integrated and used. We're seeing that is kind of a lack. Yeah, go for it.
For schools, really focus on a brief model because we understand if they're at school, they need to be in classroom if we can get them there. And then, in addition to that brief model, is making sure that we're making services happen where the student needs to grow. So that's the provide across settings, so they can generalize to the actual environment they're going to be using these skills in. And so we're non-traditional in approach. So we push into classrooms. We'll run groups in the back of a classroom when there's unstructured time. We'll run intramurals during recess and lunch and things like that. Because we know if we pull kids out into an artificial environment and provide those services at a clinic, somewhere else off campus, it doesn't always generalize back. No matter how much you team, we have to push those services where the kids need them. And so we've seen a lot of growth with that too. Kids want to engage. And as you get some kids engaging, then you have opportunity for others. And this is where that tier 1 and tier 2 can be a big push. Because if you're providing a group on campus that other students see and they want to participate and engage in, then all of a sudden you have large cohorts of kids that are getting access to mental behavioral services.
Yeah. Which leads us to teaming, right? So all the service providers, teachers, family, all the adults that are in the student's life, I think we just need to do a better job at talking to each other, getting in the same room, talking about the challenges that we're seeing, talking about the goals that we're targeting, talk about the progress, the wins, so that we're really making sure we're not duplicating the service and that we're being really efficient in our application to get high quality care out there. So next slide, please. All right, so braided funding. Let's get into the approach of how we get this all paid for. So at Pacific Clinics, we take a braided funding approach, which most CBOs do, because we know there's not one identified funding source that kind of covers all of the needs that we have. So, there's federal, state, Medi-Cal-based funding, BHSA, community schools, and other grants. But today we wanted to really highlight the CYBHI multi-payer fee schedule and how this really is turning out to be a sustainable pathway to get a bulk of these services paid for. Mm-hmm. And we could support all students through this approach. So we're really excited and to be able to be a part of this initiative. We have certified 100 wellness coaches at Pacific Clinics. And in our school-based programs, I believe we have about 350 staff. The rest are BBS track folks. social workers, licensed marriage family therapists, and folks on track to be licensed. I don't know if there's anything, Patrick, you wanted to add on the braided approach.
Yeah, whenever we talk about braided funding, I like to emphasize that what this initiative creates the idea of sustainability and consistency, because we've all supported families that are they're not so invested in services because they don't think it's going to be around. They've had that experience in the system where they have a provider, the provider leaves, or the funding changes, or whatever. So the idea with this is no, this is going to be a long-term plan. It's not tied to school funding. It's tied to health plans, and hopefully those don't go away. So this is a much more sustainable model. So we can communicate to families and the community at large that no, this is something that's going to be here today, tomorrow, and next school year, and hopefully years from now.
Yeah, and what we're really hoping to do too, if we go to the next slide, I think it's probably a good segue into kind of an embedded versus an affiliate partnership with a CBO, whether it's Pacific Clinics or another CBO that you have in the area that you're already working with or you want to work with. There's two pathways. So the embedded route is when there's a contract with a financial agreement. So this is saying, hey, PC, I want to be in an agreement with you where we are going to pay for these services up front. And then on the back end, we are going to file claims and get reimbursed for the services that you provide. So on the embedded side, district makes the referral. Pacific Clinics provides the SPI roster for those of you that have gone through onboarding with Carelon and DHCS. I'm sure you've got your SPIs ready, or if you're going into a cohort or getting ready to embark on this endeavor, the fee schedule, the SPI roster is just a fancy way of saying a list of all of your staff, your providers, who's on campus providing these services. So we provide that. And then district collects student health plan information. And then we provide a monthly rendering of the services. And then that goes to district. District files claims with Carelon, and then those claims, when they come back, they collect the reimbursement. So that's the embedded route. The affiliate route, so we are statewide affiliate providers, which means we can provide these services to any LEA across the state of California. And in this agreement, it's typically an MOU, so there's no financial agreement tied to this. It is basically an allowance that says district can make referrals to us. And so when district makes referrals to us, we're following all of the tiered intervention, assessment planning. We're collecting the health plan information. We're documenting in our electronic health record, and then we're filing claims to seek reimbursement. So what is a benefit to LEAs for affiliate status is that we get to show up and do the work. We do some teaming, and then on the back end, we have to figure out how to, collect the funds for the service. And then the shared experience across whether it's embedded or affiliate is just the teaming and the care coordination.
It's often the same teams. So we're trying to braid on the back end what our funding looks like. So we'll have school districts that will contract for little bits and pieces or for, full staff. And they want to fill gaps with things because maybe they have some grants that they want to use up to make sure, certain services are in place or to run SEL in classrooms and things like that. And then there will be an affiliate to provide services. We do have to acknowledge that occasionally it's going to be students that can't be served through our affiliate services because they don't have a health plan or it doesn't qualify for some reason. And so the school districts that we contract with will leverage that contract to fill gaps that fee schedule just can't cover. And that really helps keep all of our team active throughout the day. Because if we are the affiliate provider to fund our staff, the reality is they have to be working all day. So we need schools as partners. Yes, you're the referral source, but without you, we don't have this program either. So partnering also means just really understanding the needs of the school and getting in at those low tier levels. So when that student's on the tip of your tongue, that's when you refer. We're not waiting until you've gone through your entire process to refer kids to us. That's the older model. This model is refer early, refer often. We want to intervene, provide brief services, and get out of the way so the student can continue to grow.
Yeah, and I've been really excited for affiliate. There's a handful of LEAs that have run out of wellness grants, various grants across the state to open their wellness centers. And they're like, hey, now what are we going to do? We have this one clinician that was assigned. We don't have a way to maintain this clinician to stay in this wellness center. And what we're able to come on and do is just to help the district get set up to bill for that clinician. And then whatever gaps are happening, we can provide the wellness coach or provide another clinician so that we can work together building the fee schedule to make sure that we cover the full spectrum of services that need to happen out of that wellness center. All right, next slide. I'll let Patrick take it from here of benefits of partnering with CBO.
Yeah, so we started talking about, at least that's where I started, was this partnership piece, is how do we partner? So I think there is some concern with schools that bringing someone else onto campus, there's risks associated with that. But we're looking at it from the perspective of just increasing access. That is our primary goal as a mental health organization. We provide services for over 150 years with the same vision and purpose, and that's to increase access to services for youth and families. And this initiative, the CYBHI initiative, allows us to really create a diverse and representative workforce to do that work. So students are more likely to engage because the individuals they're working with, they can relate to. I'm a therapist by trade, but I also get not everyone's therapy. I don't think I want therapy sometimes. I just want someone to talk to and that will listen to me. And you don't need a special degree to do that, but you do need some training. And so that's what a CBO can provide. And we can scale that with need. So if we have 100 referrals, it's a few staff. If we have 1,000 referrals, it's a few more. And we can adjust based on need. And we know the need shifts around. You might have one school that needs it today and this month, and at the end of the year it shifts or a different school district. And we can move with the needs. And we also help identify those needs. I've worked in schools long enough to know that universal screening is a very scary thing for schools. If you identify all the need, then you have to provide those services. And how do you possibly scale when your funding doesn't change just because you identified more kids? And that's where partnership is so critical to increase access once you get those kids identified. We shouldn't be afraid to ask kids if they're healthy or not. We should be able to do that knowing that we can provide services when they need it. And with that partnership, the gaps can be filled. We're not here to take over schools. It's a partnership. But we want schools to be able to do their jobs and educate. And we need to serve kids across all the tiers. And that's what we've been working as a CBO and as just an organization within the field is to help understand schools more. We get that not all mental health professionals get schools. We understand that. So we're trying to change that perception of what mental health can be on a school campus. Understanding that it's not always on a school campus. Sometimes we have to engage families in other ways so they'll even access services. Post-COVID, we've seen a huge shift for a primary referral reason. It used to be anxiety, depression, that externalizing behavior. Now it's school refusal. That's new. We know we have to engage families differently, knowing that referral reason. And we can do that. We can go to the home. We can provide services in the community. We're year-round. We provide services during the summer and during school breaks. Students struggling at the end of the school year, they're not going to magically, come back in August and be a different person. The family needs support. So we fill those gaps, provide transition services throughout summer, throughout breaks. And then we can just refer to a broader system. The benefits of partnering is that you're leveraging our entire team, which is not just the people that are in front of you today or on your campus. It's all of our employees. It's a resource behind us, the people that we can talk to get services referred. In the region, we have other programs that are providing, especially mental health services. We have a special education team that's supporting Weston SELPA. So we have capacity to build relationships beyond even the CYBHI initiative, which is fantastic. I mentioned also that, as an agency, we train. I'm not saying that schools don't train. Of course, schools train. But I worked in schools. I worked in special education. I was a school day employee only, which means I showed up on the first day of school. I did some trainings while I was getting to work. And then when school was out, I was done. Our staff are 12-month employees, and they become subject matter experts beyond just the services they're providing. We extensively train our staff on care coordination, evidence-based practices. We integrate social emotional learning. We can adopt your school's social emotional learning curriculums. And we tailor to those needs. And then it's ongoing staff training. Our staff are always looking to grow. A lot of our staff that start as wellness coaches, They go back to grad school and they become, social workers. And then they take over our programs because they have that passion and vision to work in schools. And then the bigger picture, the bigger umbrella of partnership is the full weight of the CBO, and that is our infrastructure. We are experts in managing information. We have entire systems and risk management to account for all the pieces that, as an educational system, do you want to have an EHR? Do you want to manage quality and audits and all those things? This is something we do. We actually have, we can support you in setting up your own systems. Think of us as a resource and as a tool in consulting on process and those pieces. We collect a ton of data, and behind that, we have the IT infrastructure to analyze it. Data is only as good as your capacity to look at it, review it, and use it, and leverage it for changing your process and systems. And bringing this all together is these pieces, along with all the strengths that are on school campuses, creates a sustainable model. By breaking these funding sources and really looking at the affiliate or embedded special education, especially mental health, we bring this expertise for health plan billing. And if we all share this responsibility together, we can bring a very strong partnership to the table that supports students, families, everybody grows. So those are many of the benefits of partnering, but it does start with meetings like this, conversations like this, where we can put everything on the table that we need and identify a path to start talking about these things.
Beautifully said. All right. So a little bit about what we've done at Pacific Clinics is we have created a program specifically for the fee schedule. And so it's our Bloom and Swerve by Pacific Clinics. We're really excited that we have our Bloom programming, which is for ages 0 to 12. Our SOAR programming, ages 13 to 25. We have our certified wellness coaches, and you could see our licensed folks at the bottom, BBS track, where we're focusing on screening and assessment, psychoeducation, case management, group therapy, individual therapy, and it is a resource if you're looking for some support. I don't know if there's anything else you'd like to add, Patrick, but I'd like to open it up to questions. I also appreciate your time.
As people are possibly typing their questions into the chat, you can feel free to unmute yourself and ask questions. But I also just wanted to reinforce that DHCS does put out information about how our LEAs and partners and CBOs are doing when it comes to submitting claims to the fee schedule. And out of 8 CBOs, Pacific Clinics is one of those CBOs that has successfully submitted claims to the fee schedule. So I do want to, lift up that work that they are doing, in this space. So please, you guys, ask the questions, because I know many of you have an interest in working with CBOs. Some of you only have one staff that may be identified as a practitioner for the fee schedule, and this is an opportunity for you to get some more insight on ways that you can work with the CBO to leverage the fee schedule so that you guys are maximizing your claim submission.
Hi, Lacey and Patrick. There is one question. I'm going to go ahead and read it. It's a question with a little statement. So it starts, how are districts handling ORP responsibilities in-house and contracted? And then they have a little statement. We have potential ORPs that are concerned about the use of their license for service approval, but they don't directly supervise the work, not being able to see clinical notes, etc.
Yeah, that's a great question. We have a lot of our licensed folk that are supervisors have the same concerns too, because when you have staff working under your license, there is a responsibility to that. But that is also how the system grows. So you just have to build a schedule, honestly, of supporting your staff if they are providing service. That is built into our process as a CBO because this is the work that we do. But I understand in schools it may not be possible to have your group supervision or whatever it might be. You just have to build it in and create that expectation for staff.
Yeah, And fidelity. I think fidelity is big on our end because, our supervisors do oversee many wellness coaches and then clinicians, right? And they're not only signing off on like BBS supervision hours, but they're supervising like what they're doing day to day. And I think fidelity to evidence-based practices was a huge shift in our supervisors being able to build capacity in our teams and then feeling really good that the work that's out there being done has a structure to it. We have data that shows how implementation is going. So I think fidelity and the regular schedules of meeting and teaming would be my suggestion for that. Yeah. Good question.
Solid question.
And I would just like to add that everybody that is submitting claims has been the responsibility of someone at some point.
Mm-hmm.
So just because you're licensed, in order to get licensed, someone above you, your licensed clinical supervisor, stepped in, sucked it up, and allowed you to submit, claims that, they may have, questioned or wondered about. I do think that there needs to be some of that oversight and guidance, certainly, documentation training, things that supervisors are kept in the loop about, regarding all the people that may be submitting claims under their license. But I just want to say, in general, this is just the path that we've all been on. If you're licensed, someone, had to, say, yes, I'm going to do it. I know as a clinical supervisor before and still providing clinical supervision, my license is, on the line for the staff that I supervise.
I love that you say that, because I think we do see that with some of our leaders, where it's an adjustment period to just be okay with different learning styles and different levels of application of clinical intervention. Because our wellness coaches, right, they're all learning this as they're going too. Like, we can provide structure, support, scope, and sequence, but none of this intervention is going to be completely perfect. And that, like you're saying, Veronica, it's just part of the gig. Like, we're here to teach and to move people along and get this to be sustainable.
Yeah, the primary intervention is always going to be the relationship, and you don't need a degree for that. And it's also very apparent when you talk to someone if they have that skill and capacity.
Yeah.
So there's another question. It's question 2. For clarification, is there a cost to take the embedded route?
Yeah, so the embedded route is a contract with financial agreement. So the embedded route is you would come to a CBO or Pacific Clinics and say, I have this much funding.
You wait. I'm chiming in.
I'm going to give you this funding. And then on the back end, we'll file the claims and collect a reimbursement. So embedded, you're paying. Affiliate, you're not paying, because that CBO is going straight to the source to get reimbursement. So there's no cost to family or LEAs for affiliate. Good question. Is there any others?
Are there any thoughts about what you've heard? Are you guys willing to consider working with a CBO to help leverage the fee schedule?
The
All
thing
right,
about
Dr.
that-
Rogers, a maybe.
We got a maybe.
So we also get questions. We often get questions like, what's the first step? And the first step is just reach out. So whether it's up to us or another CBO, reach out and talk to them. You'd be surprised what they can offer or what we can offer. You won't know unless you ask.
And I would say just pilot it. Like, it doesn't have to be, we have some, LEAs that they've signed MOUs, and we're going to universally screen 20,000 kids, and we're going to provide services to 20,000 kids. But we also have LEAs that we talk to that they say, hey, I want to start with this one school with these 5 kids. So I would say pilot it. Just see if it works. See how you like it. See if it's of benefit to you. And I know not all CBOs are, we're not all the same. We all have our own specialized application of services too. So that's something to look into too.
Well, are there any other questions while we have Pacific Clinics here? No? Okay. Well, I will give you guys about 20 minutes of your life back. Thank you guys for joining us. And we will see you in maybe 2 weeks. I think will be our next meeting. Thank you,
for
Dr.
having us.
Rogers. I'm happy you joined us.